going to speak on this
Yeah, I'm going to point out KMA later, but I think the Board of addressed a lot of issues in there.
Touch on this side of the table. What's up over here?
How are you?
Watch who you're running with.
If we can see everybody take their seats, I think we have enough for a quorum. It is good to see everybody milling around and enjoying each other's company. It's a welcome return to some normalcy here for our legislative meetings. This is the Interim Joint Committee on Health, Welfare, and Family Services, meeting number 1. The date is Wednesday, June the 16th, 2021. Madam Secretary, please call the roll.
Senator Rocky Adams. Here in the room. Senator Byrd.
Present in the room.
Senator Carroll. Senator Givens. Senator Harper Angel. Senator Howell. Senator Kerr. Senator Meredith.
Present in the room.
Senator Nemes.
Present in the room.
Senator Wise.
Present in the room.
Representative Bentley.
Present in the room.
Representative Bowling.
Present.
Representative Bray.
Present in the room.
Representative Birch. Representative Dodson. Representative Elliott.
I'm present in my annex office, but you have the committee room muted, so we're unable to hear you on Zoom.
Try to write in chat. We'll try to fix that. We'll try to fix that as soon as possible.
here. Isn't that cute?
Representative Fleming.
Present in the room.
Representative Frazier.
Present in the room.
Representative Marzian. Representative Gibbons Prunty.
Present in the room.
Representative Rayburn. Representative Raymond. Sorry. Representative Riley. Representative Sharp.
Here in the room.
Representative Sheldon.
Hey, here in the room.
Thank you. Representative Tate. Representative Weber.
Present in the room.
Representative Westrom. Representative Wilner. Chairman Alvarado.
Present in the room.
Chairman Mosier.
Present in the room.
All right, very good. We have a quorum, so we're established to do business here. Hopefully those who are on Zoom, can you hear us okay? Can I see a nodding of heads? I see some thumbs up there. Yes? Okay, good. We want to make sure if there's any issues, you can always use the chat function to let us know. I would always remind anyone who's dialing in, if you can keep your mute on until it's time for you to speak, for those who are presenters as well. A few announcements before we get started. I know this is our first meeting. Hopefully everybody's enjoyed their break. The Medicaid Oversight and Advisory Committee is going to be meeting in room 171 at 3 p.m. following this meeting. I know a lot of us are on that in that committee as well. And also, just to let people know ahead of time for August, the Interim Joint Committee on Health, Welfare, and Family Services has been approved to meet at the Kentucky State Fair on August the 26th at 8:30 in the morning. So for those of you who attend that ham breakfast, we'll be immediately following that. There'll be more information that will be sent to members closer to the meeting date. If you want to make sure that you can, again, if you can mute for those of you who are watching on Zoom. All right, very good. Before we get started, we do have a special introduction from Chairwoman Mosier. She has a citation to read, so I'm going to pass it over to her.
Thank you, Mr. Chair. I would like to just present a citation from the House of Representatives to Mackenzie Longoria, who's with us today, in honor and recognition of World Elder Abuse Awareness Day, which is June 15th, so that was yesterday. We join with the citizens across the Commonwealth in observing this global event. It was launched on June 15th, 2006 by the International Network for the Prevention of Elder Abuse and the World Health Organization at the United Nations. This important event was established to provide an opportunity for communities around the world to promote a better understanding of abuse and neglect of older persons by raising awareness of cultural, social, economic, and demographic processes affecting elder abuse and neglect. It goes on, but I won't read the entire thing, but we do want to recognize this important day and certainly highlight elder abuse and awareness and continue educating on that front. Thank you, Mr. Chair.
Thank you for that, and I think we all share the same sentiments. We know that that'll be a topic of discussion for us a little bit later on in one of our interim meetings. Kentucky has some work to do on trying to improve our rankings in that regard as well. As you can all see, we've got a very aggressive agenda, so I thought we'd address first item number 9 on the agenda, which is a consideration of referred administrative regulations. There are quite a few regulations. We've had a chance to review all of these. There is action on one that we'll have to take. First of all, before I go into that one, there is a letter in your packets from the Kentucky Medical Association. They asked us to distribute this to all members regarding 201 KAR 2:380. Has to do with board authorized protocols from the Board of Pharmacy. I believe that this is a letter that was issued in February as this reg was being put together, and I think some changes and amendments were made to address some of those concerns. But again, it's always a concern from the KMA in terms of just scope of practice with issues in the Board of Pharmacy. However, the way it's drafted, I did not see any concerns or issues with that regulation. I do draw your attention to 902 KAR 045190, which is a proposed regulation it's regarding hemp-derived cannabinoid products, packaging and labeling requirements. And hopefully there's some members of the administration who are on the call. There's a request for, again, an amendment to this regulation. Are you available? You on the Zoom call?
Yes, sir. This is Julie Brooks. I'm the Regulations Coordinator with the Department for Public Health.
Thank you, Ms. Brooks. If you could just briefly tell us the need for the amendment and for the change in that regulation.
Oh, certainly. After the Administrative Reg Review Subcommittee meeting, the department was contacted by a couple of different entities, one representing the hemp industry and one representing the Retail Federation, about some concerns, some language in the regulations that wasn't quite, or in the regulation that wasn't quite clear. So we, in talking with staff here in the department, agreed to do an agency amendment to make it clear that for the Retail Federation, their concern was that the language would require anyone who wanted to sell CBD products or products that contain cannabinoids would have to register with the department. And that's not what we wanted. It was more those that would be manufacturing it in a finished product that would be an ingestible finished product. So we agreed to make that change. And then there was concern raised about what would a physician say, because the regulation said that, you know, the label should say to consult your physician before use. So there was concern raised about what would a physician tell someone. So after talking with staff here in the office, we agreed to remove that from the regulation as well. So that's what this agency amendment does.
Very good, thank you. So the proposal, for those of you who might be looking online to see what the actual, here's the actual change, and I'll make the comments of what they want to see changed in the regulation is under Section 2, subparagraph 1, after the words seeking to manufacture, to delete the following is a comma, market, comma, sell, comma, or distribute. And then in Section 3, subparagraph 2, subparagraph H, delete all of paragraph H except the semicolon and the word and renumber paragraph I as paragraph H. Is that your understanding as well?
Yes, sir.
Very good. Any questions regarding that? If not, we'll entertain a motion for approval of the agency amendment. There's a motion. Is there a
Second.
second? There's a second. All right, this will require a roll call vote. So any other discussion or concerns? Madam Secretary, please call the roll.
Senator Rocky Adams. Senator Berg.
Aye.
Senator Carroll.
Aye.
Senator Givens. Senator Harper Angel.
Aye.
Senator Howell. Senator Kerr. Senator Meredith.
Present in the room.
Senator Nemes.
Aye.
Senator Wise.
Aye.
Representative Bentley. Yes. Representative Bowling.
Yes.
Representative Bray.
Yes.
Representative Birch. Representative Dodson.
Yes.
Representative Elliott.
Aye.
Representative Fleming.
Aye.
Representative Frazier.
Abstain.
Representative Marzian. Representative Gibbons Prunty.
Yes.
Representative Rayburn.
Yes.
Representative Riley. Representative Sharp.
Aye.
Representative Sheldon.
Yes.
Representative Tate. Representative Weber. Representative Westrom.
I abstain.
Representative Wilner.
Yes.
Chairman Alvarado.
Aye.
Chairman Mosier.
Aye.
Very good. So that amendment has been adopted to that regulation. Any other discussions on any of the regulations that are before us? I know there's a long list there. If not, allow the record to show that we have done our obligation to reviewing all of these regulations before the committee. Next item on the agenda is going to be item number 8, which is the legislative hearing on the Child Care and Development Fund Block Grant Preliminary State Plan. I don't know if Director Vanover and Director Day are on the call.
Yes, we're here.
Very good. If you want to just very briefly present the information in the block grant preliminary state plan, we would appreciate it.
Not a problem. So, Division of Child Care receives annual funds from the Child Care and Development Block Grant that are specifically designated to child care services throughout the state. Kentucky receives approximately $90 million per year, and then we must contribute a state match to those funds. The funds that we contribute are typically about $10.6 million in the CHFS general funds towards the subsidy program, as well as $10 million in tobacco master settlement funds that goes towards our All-Star program and scholarship programs. For the money that is contributed from the federal government, top priority of the funds is to assist low-income families and at-risk families, including children in foster care, families living in homelessness, things like that. Assist them to access high-quality child care. And then the other top priority is quality programming and monitoring. All block grant funds must help the state to meet the guidelines established in the 2016 federal rule for the Child Care and Development Block Grant. There are required percentages that we must use to distribute these funds. At least 70% of funds issued to the state must go towards direct services, and that is typically subsidy. Our office distributes those funds directly to the centers, but for the families. So it pays for the children's tuition into the child care programs. A maximum of 10% is used for administrative funds. At least 12% must be used towards quality services, and that out of that 12%, at least 3% has to be used towards infant toddler initiatives. Kentucky typically spends about 15% on quality initiatives and well over 70% on our direct services. The quality projects in Kentucky used for these funds include our contract with Division of Regulated Child Care for monitoring and investigations, our contract with the University of Kentucky for coaching and training, our contract with EKU for our professional development statewide registry, contract with Western Kentucky University for the Family Child Care Network, and our contract with DCBS for the National Background Check Program. The subsidy money that we use includes not only payments to centers for low-income families, foster children, parents who are full-time students, or families experiencing homelessness, but it also includes accountability measures to prevent fraud and reclaim funds from fraudulent payments. Federal accountability is also attached with these funds. We have monthly meetings with our federal and regional partners, 6-month audits on payment and claims in order to look at error rates, and 6-month reports on services offered that are issued not only to the state and LRC, but also to our federal partners. And then they also do a site visit in the state of Kentucky every 3 years to review how the funds were used and that all of our projects are meeting the goals of the federal rule established in 2016 at this point.
Very good. Thank you. There's some information again in everybody's packets as well. Any questions? Seeing none, very good. We thank you. We appreciate the information. And again, the records show that we've reviewed the block grant as presented before us. We appreciate it very much. Thank you. All right. As you can all see, we've got several presenters. I know I've gotten several requests from individuals who are attending remotely, and so trying to be in the interest of time to help some of those folks who are here to testify. Let's go ahead and jump down to item number 7, which is the Rare Disease Advisory Council update. Some of you may know we've had some bills filed this past session regarding some rare diseases, and this is a council that was established about, I think 3 or 4 years ago now. And so there's been some change in leadership there, and we're hoping to reactivate this council. So I wasn't sure if Mr. Klausing, if you're on the call.
Yes, I am, Senator.
Very good.
Thank you.
Thank you. Good to see you again. If you'd like to introduce yourself and just give us a brief update as to where we stand on the council, and the floor is yours.
Thank you. And thanks for your accommodation. I've got a deposition at 1:30, so I'll be brief to everyone's pleasure, I presume. So yeah, my name is Joe Clausing. I am the chair, I guess recently elected chair of the Kentucky Rare Disease Advisory Committee. I was appointed by Governor Beshear about a month ago. So I'm literally looking forward to taking this committee off the ground and taking it to new heights. I've been on the committee since it was signed into law in 2019, but for whatever reason, it didn't move as fastly as some of us would like. So we're looking forward to moving it and to continuing to keep your committee updated with our progress and being a good resource for all of you as we navigate policy decisions that will impact the rare disease community. We'll have 16 members on our committee. It'll be a diverse group representing all of the rare disease caregivers, patients, healthcare providers, researchers. I would like to get someone on board from Medicaid to help deal with the challenges that folks receiving that experience with rare disease. It's become a common model in other states, including Illinois, Tennessee, Ohio, Virginia, and West Virginia. I'm presently contacting other previous members of the ART Act to make sure they still want to be on board. But I'm also the executive director of Cure CF. So as a father of a 14-year-old with cystic fibrosis, this committee is near and dear to my heart. And I thank you and others for the recent passage of Senate Bill 44 and 45, which help our rare disease folks. We're few in number, but we have severe challenges and obstacles to overcome. So I'm happy to answer any questions that anyone from the committee may have.
Thank you, Mr. Klausing. Any questions we have for Mr. Klausing? I just wanted to thank you very much for I'm looking forward to your leadership on this. I remember your testimony during this past session on, again, Senate Bill 44 and 45. We were very happy to get that through our committees and through both chambers, and that's become law. But looking forward to your leadership on this. Good luck on that deposition here in a few minutes.
Thank you so much, and thanks for your accommodation. Have a great day.
Well, with that in mind, let's go ahead and we're going to probably in reverse order here, but we've got a lot of folks that are here regarding a couple of disease states that some of you may have seen, and I know some that are particularly important to some of our members on our committee. We've got some other individuals who are, again, out of state and zooming in. So we're going to start with item number 5, which is the pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections syndrome, that's known as PANDAS, and also pediatric acute onset neuropsychiatric syndrome, PANS. We have Representative Melinda Prunty, who's going to come before us here, and she has several individuals who are waiting to testify, and I know they've got to be somewhere here shortly, so we thought we'd try to accommodate their testimony. Representative Prunty, if you'd like to begin and introduce your guests. And as all of you introduce yourselves, I know everybody has brief testimonies. Introduce yourselves for the record, and the floor is yours.
Thank you, Mr. Chair. And thank you, committee members, for hearing this issue today. I'm State Representative Melinda Gibbons Prunty, and I represent the 15th District.
I'm Kelly Joplin, and I am a resident of Somerset, Kentucky.
And one of our members is in the restroom, so he'll be joining us shortly. Michelle?
Yes, hello. I'm Michelle Liberatory. I am a parent of a PANDAS patient, and I am in Campbell County, Kentucky.
And then Dr. Drayton Agayu. Are you with us, Dr. Agayu?
Yes, my name is Tana Galil. I'm an associate professor in the Department of Neurology at Columbia University in the city of New York.
And then Dr. Nate Mitchell, are you on? We weren't sure if he was going to be able to join us, but I really appreciate you accommodating, because Dr. Agayu, I hope I pronounced that correctly, cannot be here after 2 o'clock. So I just want to tell you, as a former physical therapist who worked with children of varying diagnoses, what first got my attention about PANDAS and PANS was an article in the November-December 2019 NCSL journal entitled Little Known Panda Syndrome Getting Attention. At that time, 16 states had begun looking at it, and issues that were raised were lack of awareness, lack of a medical diagnosis code to bill for services, and lack of insurance coverage. Some states began requiring insurance to cover PANS and PANDAS. Other states set up advisory councils to advise their health commission, cabinet, and legislature on research, diagnosis, treatment, and education. States that mentioned that had taken some type of action were Georgia, Illinois, New York, Oregon, Arkansas, Minnesota, New Hampshire, and Texas. Staff here subsequently set up a call with the National PANDAS PANS Network, which began ongoing conversations with parents here in Kentucky that connected me by that initial call. Parents from Louisville, Northern Kentucky, and Somerset. And I've learned of recent diagnoses in Daviess and Boyd counties as well. Those conversations led to House Concurrent Resolution 78 of the 2020 regular session, asking that a task force be established to study PANS and PANDAS here in Kentucky. What is the incidence, where are the children and the families affected, and so on, and then subsequently make recommendations. We were able to present to the House and Family Services Committee, and COVID prevented getting in front of the Senate Committee. COVID also dominated the 2020 Interim Committee as well. We decided to take a different approach in 2021, and House Bill 180 was filed to establish an advisory council in the cabinet rather than a task force, but was never heard. However, it did lead to conversations with both chairs Alvarado and Moser, along with the cabinet, trying to figure out where PANDAS and PANS fit in order to obtain the desired goals and meet the needs that were identified. The Children's Health Technical Advisory Council and the Rare Disease Advisory Council were both mentioned. However, it didn't fit under the Children's Health TAC because it does not have a broad enough scope of disciplines represented, at least initially, to dig into the various aspects that need to be addressed, and the Rare Disease Advisory Council had not been functioning for quite some time. We did not want it put in File 13. These kids and these families need help, especially the ones who do not have parents who are as committed, educated, and passionate as the ones you're going to hear today. And it should not take 10 years to get a diagnosis, and grandparents shouldn't have to cash out their retirement to obtain treatment that can only be accessed out of state. So thank you once again, and from here I'm going to turn it over to my panel of distinguished guests. Dr. Agayu.
Thank you, Representative Prunty, for inviting me here. So I am an associate professor at Columbia University, and I'm also a research scientist who for the past 10 years has basically worked on this disease. So in my laboratory, we work both on animal studies for this disease using multiple infections with group A strep, which is the causative agent for the disease. In addition to that, we do human studies to understand both the inflammatory response in the sera obtained from the children, as well as to perform genetic studies to look at the genetic risk factors for the disease. And so what I want to state here is that based on the collective work that my laboratory has done for the past 10 years, using both animal studies as well as human studies, we have very strong supportive evidence that, contrary to some of the statements you'll hear or you will read, this is a neuroinflammatory disease that requires special attention and treatment. And we have very strong evidence of the involvement of the immune system in the generation of both neurological and psychiatric manifestations that debilitate children. So, I didn't have time to present you some of the slides because I thought that this should be a broad discussion, but I'm happy to answer any additional questions that you may have regarding this disease.
Can he go ahead and field questions now? Since
Sure,
he needs
yeah,
to get off? Okay.
absolutely. So any questions for Dr. Gayu? Yes, Representative Bentley.
Thank you, Mr. Chairman. Doctor, what specific antigen or protein from the Streptococcus is being attacked by the human body?
So usually the type of the protein that has been mostly implicated in the disease is a surface protein called the M1 protein. In fact, the group A strep that has this surface protein M1 is the one that we also use in the laboratory to generate the mouse model for the disease. However, whether this is the sole cause of the disease, it's unknown because basically currently it's unclear whether this strain only or other strains of Streptococcus are able to cause the disease. And in the cases of children who suffer from the PANS, where basically the causative agent is unknown, we have also evidence that indeed, even at the time of the presentation, they may not have infections with group A strep. These infections are very common in children. And so any child at any time point, gets an infection with group A strep. But our genetic studies do show that indeed, that these children that have this disease have genetic risk factors that impair the immune response to group A strep.
Thank you, Doctor.
Representative Sheldon.
Yes, thank you. Appreciate that. I know it sounds like you've been in this research for many, many years. I wanted to quickly ask, the rare disease component of this is just, I've dealt with something very similar, not exactly the same, but do you have any diagnostic, something that, a test that firmly authenticates the presence of this particular disease, or trying to diagnose it? Is that seems like it's a big issue, like several years sometimes before some of these people get diagnosed?
So that is still an outstanding issue. One of the panels that was developed a few years ago by Dr. Madeline Cunningham at the University of Oklahoma was a panel to identify antibodies that recognize surface proteins on the neurons called the dopamine receptors, D1 and the D2 receptors. Now, this test has put into question by some studies. So currently there is a need to develop better biomarkers. We actually have identified 10 distinct inflammatory molecules in the blood of these patients that we're aiming to publish in the near future, and that potentially could be as an additional biomarker. But currently, I think more research is needed to firmly establish basically tests that can be ascertained for the diagnosis of the disease. And the diagnosis right now is predominantly based on the neurological and psychiatric evaluation. Here at Columbia, we have a dedicated team of a child neurologist and a child psychiatrist who both have to evaluate the patient for a clear diagnosis.
Thank you very much, Doctor. We sure appreciate your work.
Senator Burke.
Thank you, Chairman, and thank you, Doctor, for your presentation. Quickly, does this have to do with untreated strep, or is this possibly a consequence of appropriately treated strep infection as well?
So it's very difficult to say, treatment of a strep. So first, there are a lot of cases in children where you can have a strep infection and the child doesn't know that it has a strep infection. And so basically, because unlike the most common form of disease, which is the sore throat, which all of us have manifested at some point in the childhood, some children don't really have a big sore throat, yet they have an active strep infection. And so a child may even go to a clinic and just become, is basically his throat may carry group A strep. And, he may not even be aware of it. However, in addition to that, group A strep has the ability to reside also inside the cell, in addition to residing outside the cell. And so when it is inside the cell, even though in itself this bacteria is very sensitive to penicillins, when it is inside the cell, it can become resistant to penicillins. And so sometimes the treatment can be very difficult because it can reside in the tonsils, it can reside in the anal area. And so treatment can be quite difficult. And therefore, for example, for the treatment of Sydenham's chorea or rheumatic fever, which are also the sequelae of group A strep infections, the physicians recommend long-term treatment with antibiotics to eradicate the pathogen.
Any other questions, members of the committee? Dr. Gayu, thank you so much for your presentation. We appreciate that. Thank you for your work. I know this is upcoming. I know we're seeing a lot of things like Lyme disease, which there's a lot of discussion around, long-term antibody and autoimmune response to infections like that as well. I'm sure there's a lot of research coming in the future. We'll be looking back at these days and thanking you for your work on this topic. So I know you've got somewhere to go. We appreciate your time today.
Thank you.
Representative Prunty, if you want to continue with your guests.
Michelle?
Yes. Thank you so much, Chair Alvarado, and thank you, Chair Moser. Thank you for allowing us all the time to testify. As you know, my name is Michelle Libertori, and my family has resided in Campbell County for the past 10 years. And just as we remember the circumstances that have changed our world, I remember the very moment that we lost our then 7-year-old daughter, Kaylin. That date was March 17th, 2019. That weekend, Kaylin was ill with a fever and was generally not feeling well. But on Monday morning, Kaylin had what we now know was her first panic attack. She was overcome with debilitating fears and the sensation that her throat was closing and that she would die. We initially thought that this was from her illness, but it lasted for hours. Kaylin then battled back-to-back panic attacks and developed contamination fears that were overwhelming. From there, she added to her mysterious list of symptoms. Kaylin stopped eating most of her foods. She suffered with insomnia and couldn't fall asleep at night until well after midnight, or if she did fall asleep, she would wake up for the morning between 2 to 4 a.m. and would be up the rest of the day. Often she was experiencing terrifying hallucinations. She was exhausted at school, we were exhausted at work, and she was unable to focus. She would not let me out of her sight at home. She experienced debilitating headaches and muscle and joint pains and developed motor tics and began losing coordination and balance to the point of falling over, and we needed to pull her from her dance classes because she could not maintain her balance. She also had aggression episodes, and we had never seen these, and she was overcome with grief after these episodes had subsided. She was even wetting the bed at night. And this all happened within a week or two of this illness that began the weekend of March 17th, and our child was quickly slipping away. The child we once knew was replaced with a tormented version of herself. At that time, we feared that maybe a brain tumor had developed or that she had experienced some sort of trauma that we were just unaware of. So I called to make an appointment with the pediatrician on my own, and I begged her for help. As I knew, as a psychology major, these weren't normal mental health issues that came up, and she was also experiencing these neurological side effects. As I listed these symptoms for the pediatrician, all she could say was, "This is so weird." And I said, "I know it's weird. What is it?" She didn't have an answer for me, but what she did do was give us a referral to a specialized crisis psychiatry group at the Children's Hospital here in Cincinnati. We were told to schedule a meeting with a psychiatrist, but before then, we met with a social worker. The social worker evaluated our daughter and gave her a diagnosis of panic disorder and gave her a list of 101 coping mechanisms, sent us on our way, and then we were to make an appointment with the psychiatrist later on. At that time, Kaylin was still suffering, and she started to develop depression and even suicidal thoughts. She was just 7 years old. It was unimaginable to me. I was frustrated and grasping at straws, so I turned to a Facebook moms group and asked for help. It was there that I learned about pediatric autoimmune neuropsychiatric disorder associated with streptococcus, or PANDAS, and that's a larger subset of a group of PANS, or pediatric acute neuropsychiatric syndrome, which can have other infectious triggers. A mother shared her daughter's story, and it was almost the exact same story as our daughter, Kaylin, except in their case, their pediatrician was able to identify it. They treated the child with antibiotics and anti-inflammatories, and that child made a full recovery. After 7 weeks of digging and still no help from school personnel or doctors that we had reached out to, I found a PANDAS psychiatrist in Northern Kentucky. She immediately diagnosed Kaylin with the clinical criteria for PANDAS. Dr. Daly told us plainly that Kaylin's immune system was launching an autoimmune attack against her brain from a strep infection, and she needed IVIG, or intravenous immunoglobulin treatment, immediately. But she had no doctors that she could connect with in Kentucky who would be willing to treat any of her patients who she has seen with the same clinical criteria. So our next best bet was to start antibiotics to target the strep and to calm her immune response. Within just 5 days of being on the antibiotics and the medication to help her sleep, Kaylin stopped experiencing her panic attacks fully, and the rest of her symptoms significantly decreased. Our daughter was returning to us. Just as we know that strep can cause an autoimmune attack on the kidneys, heart, and skin, as in scarlet fever and rheumatic fever, strep and other infectious triggers can also cause an autoimmune attack on the brain, specifically the basal ganglia, and this has caused all of the symptoms that our children have been experiencing. Antibiotics have been helpful with keeping us afloat over the last 2 years, but Kaylin was still experiencing the aftermath of her brain inflammation that she did not get the proper treatment and diagnosis for right away. And so hers quickly became a chronic state. My daughter needed more advanced interventions, but there had been no one in the state of Kentucky knowledgeable or willing to treat. Tragically, many medical professionals and school personnel in the state of Kentucky have no knowledge of PANS or PANDAS, and children will continue to have a downward spiral of declining health and cognitive impairment if we don't try to make an impact now. Thankfully, we were finally able to receive IVIG treatment for Kaylin with the collaboration of a doctor from Cleveland, Ohio, Dr. Jan Krawinski, and a neurologist at Children's Hospital in Cincinnati. However, this came a year and a half after Kaylin's symptoms started. In spite of this, I am happy to report that Kaylin is now in a much better place than she had been 2 years ago, but our battle is far from over. I am urging you to please consider the stories that you hear and think of the families like our own whose lives have been turned upside down. And please be sure to look at the clips that were sent to you by Representative Prunty, and you will see other stories like ours and the testimony of Dr. Jan Krawinski, who was so instrumental in our help. Thank you so much for listening.
Good afternoon. My name is Kelly Joplin, and I'm a PANDAS parent. I'm also a professor at Campbellsville University. I'm a representative of our Southeastern Pandas and PANS Association, and my son battled this disease for over 10 years here in Kentucky. The diagnosis and treatment was not to be found. The PANDAS Network estimates that almost 1 in 200 children may have PANS or PANDAS. This is not rare. As Dr. Alvarado mentioned, we're learning it's about science every day, and what we're learning is that it's a lot more common than we think. Based on the numbers, we actually estimate there may be up to 5,000 children who may be suffering, whether it's a mild case or a moderate case, though we do know that it does exacerbate over time. As stated in the handout that I've given to you all, children with this disease frequently receive a diagnosis of Tourette's, OCD, anxiety, depression, oppositional defiance disorder, mood, anorexia, autism, and even childhood schizophrenia. The prompt treatment of pandas are just requires no more than antibiotics and steroids. We know that if we can restore the motor health, mental health, and cognitive functioning can be done promptly in a safe, cost-effective treatment. Generally, the longer a child remains undiagnosed and treated, the greater the cost to treat these children, including the IVIG that Michelle mentioned. Nationally, 33% of children see more than 5 doctors before being correctly diagnosed. Our family sought care for over 10 years and 15 medical professionals before going out of state to visit a national expert in Washington, D.C., receiving IVIG and then follow-up care at the University of Arizona Pandas Clinic. 44 states are working right now and have passed legislation related to this disease. Currently, 5 states have bills mandating insurance coverage for severe pandas and pandas. In addition, 10 have developed an advisory council that raises awareness and can make recommendations through an interdisciplinary panel to work with doctors, therapists, and schools to raise awareness and to promote access to care and treatment. Nationally recognized clinics are located at Stanford University, Yale, Columbia, University of Arizona, and now the University of Arkansas. Last year, lawmakers in Arkansas developed a clinic and interdisciplinary panel at the University of Arkansas, and the bill was passed after a child who was diagnosed with pandas was waiting on insurance decision whether to cover IVIG when he died by suicide. So many Kentucky families are suffering. We are just a tiny few who are well enough and educated enough to articulate to you all here today that children should not have to travel to other states for treatment and care for this devastating illness.
Thank you. These are tough ladies here. Sorry. Thank you so much. Thank you for having us today. I know we have I apologize. Mark Kleiner. I had stepped out when I think you introduced us. Appreciate you having us, and these ladies are very tough. I'm also guys are supposed to be tough, right? Panda's parent. Sorry. It's okay. I need my wife to do this. But I've been in the health insurance industry for 30 years. I am involved in the Health Insurance Advisory Council, on the Corrections Commission, and a variety of other things in Kentucky to help improve healthcare. And just really, if you take a look at everything we've done today, we really want to create a task force that'll help study this a little bit more. And education is the key, because there's one thing that we all have in common as Pandas parents is that these symptoms, the symptoms come on overnight, and your kid changes. And this is real. This is real, and you can talk to each person, and it's the same thing. It's the paranoia. It's OCD. Our son spent 2.5 weeks in the psych hospital at Norton, trying to treat the symptoms, and then eventually he had IVIG and he had plasmapheresis. He's doing much better, but he still has issues. He's still to get him to bathe. He thinks the water's dirty. Food sometimes thinks the food is contaminated. We really just want to help with some of the diagnosis and some of the treatment and protocols, and so that physicians can understand this. And if they see a sudden change in behavior overnight with all these symptoms, that they might consider the low-cost antibiotics and the anti-inflammatories, and we can keep the kids from having to go through what Michelle's son went through for 10 years. Fortunately, we had a neurologist who believes in it and treated our son earlier, and he's doing a lot better. So thank you again for your time today, but we really love to create this task force so that we can just educate people that this is real. Thank you.
We're open to any questions.
Thank you very much. Representative Marjan.
Thank you, Mr. Chair, and thank you for your testimony. The IVIG, is that chronic? They have to go in so often and get it, or is the one shot and it clears it up.
My son had one high dose round of IVIG, and it took about 3 to 6 months when we saw a change, and he started to feel better. Some is just one, and some have to have it more often, depending on what their needs are, and I guess the severity. And it's not, of course, it's not every child who has pandas or PANS. There are mild versions, there are moderate versions, and then there's severe versions. And those, Dr. Agaloo talked a little bit about that genetic disposition, and so we're finding that we are the blessed ones.
Right.
So if I can intersect for a second there to answer, this is Nagalio from Colombia. I think there some part of the NIMH PANS consortium who developed the guidelines for the treatment of the disease, and those guidelines state that indeed part of the treatment is the antibiotic treatment with anti-inflammatory, but when these don't work, then you really need to get rid of the bad antibodies that are circulating in the bloodstream. And one of the approaches is the IVIG approach. Typically, you want to limit this to basically 1 or 2 injections, but in severe cases, it is sometimes needed to give more than 1 or 2 IVIG treatments. And these are expensive, but these are now common practice in a different type of disease called autoimmune encephalitis that where antibodies attack the nervous system. And we have indeed found that there are a lot of similarities between that disease and pandas and PANS. And so, that treatment should be common now because it is used in other neurological diseases.
Thank you.
So basically, we're just trying to catch it early, help the kids so that they don't have to suffer, and also with the low cost treatment, the 2 weeks in the hospital for the psychiatric stay, the IVIG, and the plasmapheresis cost our insurance company hundreds of thousands of dollars. So we just want to raise awareness. So that's the key. And from an insurance perspective, prevention has been proven that helps prevent disease. It's costly on the front end, but then you save money in the long run. So again, thank you for having us.
You have 2 more questions, Chairwoman Mosier.
Yes, thank you, Mr. Chair, and thank you so much for your testimony, all of you. It's nice to see you, Michelle, and I really appreciate your coming and reintroducing this. I mean, we've heard this before, and it's the more we talk about it, the more organized everything is starting to feel. I appreciate that the advisory council is kind of up and running again, and I'm wondering if I mean, I have a lot of questions, but I wonder about prompt diagnosis. How readily available is it? I mean, is it really a lack of education and awareness about this that pediatricians don't necessarily test for this right away, or is it just the lack of is the testing just not available?
I think from my perspective as a parent, our experience was pediatricians are very compassionate and listen, but also they feel like because it presents psychiatrically that they want to pass it off to mental health. And I think because it is a sort of, I think the term is cross-disciplinary approach in terms of neurological and psychiatrically, and sometimes it presents, in different orthopedic issues because it is so complex that it does take all sorts of different professionals to weigh in. And in terms of a clinical history, having that is, I think, really key. So I think a lot of it is just education and providing perhaps more up-to-date information to our medical providers.
Okay. If I may, one more quickly. Do you see an opportunity in the Rare Disease Advisory Council to work, to have a subset or a work group on PANS or PANDAS specifically, rather than creating a separate task force? I think the Advisory Council would be more long-term, task forces are typically really time limited.
I would be open to that. I was not aware that it was getting started again, and I would be glad to have conversations with the new chair and see how quickly we could move on it.
Right. I mean, I just think that we have the infrastructure in place, and we obviously have the knowledgeable, advocacy group. And I just think that, it's kind of a group that's already set in place for a work group. So, I look forward to hearing any recommendations that come from this group. So thank you.
Representative Sheldon.
Yes, quickly, I want to thank you so much for just being here and sharing. I heard the words come out of your mouth several times, and it just rings so much to my heart, and I know what you must be going through, but this is real. I kept hearing that. What that tells me is that Western medicine probably hasn't accepted this the way you would have liked to have had it accepted for your child. I've been through something similar to that. And then I think the other testimony we heard was they pass it off as something psychological. Unfortunately, there is a tendency, certainly in Western medicine, to be too quick to pass it off. And I want you to know that I feel every piece of the frustration that you're feeling. And your health insurance, you talked about that, and that'd be my last question. But because it's probably not recognized as a quote-unquote real disease by some, are you having trouble, or do people typically are having trouble getting the insurance paid for it?
Correct. And a lot of times, and I talked to an immunologist and neurologist just a couple days ago, and I just leveled with them. And they weren't going to tell me this, but I'm smart enough to know. I said, basically, it's a rare condition, right? And doctors are scientists, so they have to see the studies, and more and more studies are being done. So it's been published now in the New England Journal of Medicine, and you got Columbia doctors that are working on this. So it's becoming more and more common. But to go and diagnose this condition and try to get the insurance company to pay for it, they're not going to do it. There is a code for it, but they're not paying for it. So what they do, and I know what they do, is they treat for a different condition so that we can get it paid for. Because our doctor said, we're going to get your son better, and he did what he needed to do to get it taken care of. So we just need more studies. We just need to let people know about what the signs and symptoms are so that they don't just try to treat it with the medications and as a psychiatric problem. That's really the big thing, and that doesn't cost a lot of money to educate people on it, to let them know about it. Because we found out because a friend watched 2020. That's how we found out. Somebody said, hey, I think that's what your son has. And my wife watched the episode, and it was exactly what our son has. So you have several doctors here. How often do you have a child that's normal and all of a sudden has 8 different symptoms, exactly the same? So so we just have to do more studies, and we need to educate people so that we can at least send them to the right people. And doctors don't have to code it as something else to get it paid for.
Thank you very much. I had a hunch of that. And I just want you to know that our prayers are with you, and we'll do whatever we can to make this, to get the education out there and get people more aware of this. So thank you very much.
Thank you.
All right, we've got 3 more minutes, and we've got 2 questions. So I'm going to ask the questions to be brief. Representative Westrom.
Thank you very much. I'm so impressed with the people testifying today. I worked for several years with Dr. Charp Mabry to expand our newborn testing. And there were so many different diseases that were not included. And every time we included one, the insurance companies went nuts. And we had to battle them for several years once we got the testing accepted and reliable and with every newborn. So you guys are on the front lines of a war. And I would just ask, Representative, if we could just have a basic sheet of information that we could possibly pass on that's very reliable with symptoms and this diagnosis, we could put it on our Twitter or our Facebook. At least people will be able to read something and see that there's something new. If they have concerns about a grandchild or a child, it might put them in a direction where they can get some therapeutic help. I really appreciate you. Thank you so very much.
We'll work on it and get it to everyone.
Representative Westrom, it's also in our packets online. There's information information sheet on this disorder. So if you click on the link there, you should be able to find at least some basic information on this disorder.
Perfect.
Senator Wise.
Very briefly, just a comment. Thank you all so much for the very powerful testimony. I'm hiding back here behind the column. Kelly, I think every year I've been up here, you've brought students from Campbellsville University in my district here, your social work students, and we've had great discussions. You probably never thought you'd be testifying today. And I also did not know your story. And I just want to thank you for being here and for sharing that. And each one of you all, very, very powerful. So please know our hearts and prayers are with each and every one of you. And thank you so much for your testimony.
Thank you all.
Thank you, Senator. All right, so I want to thank you all very much for coming here today, for presenting. This is an awareness campaign, really, for a lot of you for this disorder. I remind people go see doctors. We're trained when we hear hoofbeats to look for horses. And so you run the basic tests, you try to find things, and when you come back and say everything looks normal, people say, well, I guess it's all in my head, doctor, and they think that's what they're going to say. And I go, no, I just don't know what you have. And that's really a conversation that's had more and more, is that we don't know everything in medicine. We think we're very fancy. And they thought we were very fancy 100 years ago. And we thought we were very fancy 200 years ago. And we've come a long way. There's a lot more that we're discovering, a lot more in the immune system that we realize is affecting disease states, affecting cancers, affecting a lot of stuff out there. And so the more we get exposed to this, more doctors hear about this, it becomes front of mind. So when they see somebody, they go, I don't know what this is, but it's weird and I've heard about this. It triggers that memory for a lot of physicians, and they can get you the right specialist to get the right testing done. So we appreciate you coming today. This is going to help. This video, I would encourage you to share it out if you can and let people know about it more and more. So we appreciate you being here today. Thank you so much.
I just wanted to give a quick shout out. My son is here today, and he's fully recovered. And if he'd stand up.
Great.
There he is.
Hey.
Thank you so much.
Thank you for being here. All right, we've got several other physicians, as you can see on the agenda. So next time we're going to cover is going to be items number 2, 3, and 4. We'll try to combine all that information into one. We have Dr. John Weeks with Norton Healthcare, Dr. Jeffrey Goldberg with the American College of Obstetrics and Gynecology, Dr. Connie White, who's Deputy Commissioner for the Department for Public Health for the Cabinet. We've got a big topic here. We'll try to cover it in record time if we can. I know it's a lot of issues. What we often try to do is cover is regarding perinatal infant mortality, maternal mortality. We have the Kentucky Perinatal Quality Collaborative, which also does a lot of work on trying to analyze data and provide us some recommendations. We know that we're trying to improve our numbers here in the state of Kentucky. So if you all would like to introduce yourselves for the record and begin your testimony, we would appreciate it.
Sure, I'll start. Dr. Jeffrey Goldberg. I'm an obstetrician gynecologist and the legislative advocacy chair for the Kentucky section in the American College of Obstetricians and Gynecologists. Dr. Weeks?
Yes, my name is Dr. Jonathan Weeks. I am a maternal fetal medicine physician with Norton Healthcare, and I will try to keep my comments as brief as possible in respect for your time. We're struggling with an increasing maternal mortality.
Dr. Weeks, I think if you wanted me to start with mine and then we could lead into yours.
Yes, I'm
yeah,
sorry.
Right. That's okay. We're switching the order a little bit. And Dr. White?
Hi, Dr. Connie White, the Deputy Commissioner of Clinical Affairs at the Kentucky Department for Public Health with 20 years of experience as an OBGYN here in Frankfort, Kentucky.
So I want to thank Chairwoman Moser and Chairman Alvarado for having us back today. This is actually a rediscussion of a topic that was covered about 3 years ago, and I realize not all of you were on the committee then. So this is somewhat of an update, and we think a good update, and really a thank you for the work that the legislature has done. If Becky Lancaster is on, if we can have my slides up, please. Dr. Alvarado will tell you that in medicine you can't give a talk without slides, but we'll try.
You can, but it's very boring,
right.
so that's all I can say.
It's hard to sit down and not move around as well. If you can get that up. Thank you. So I want to start off today just with a brief introduction to the whole concept of maternal mortality, not exactly a light topic of conversation, but one that's very important that we, okay, thank you, that we have an understanding of why this is so important. So the truth is that while a lot of people think the job of an obstetrician is to deliver babies, that's really not what modern obstetrics is about. Delivering babies is the fun part. But the whole field of modern obstetrics came about in order to prevent maternal morbidity and mortality. And we've been fairly good at it over the last 100 plus years. And as those outcomes improved, we've actually shifted our focus somewhat to improving morbidity and mortality among babies as well as moms. Why is this an issue? If you look at the reasons for infant mortality, most infant mortality is actually what we call neonatal mortality, meaning it's mortality that occurs within the first month or so of life. And outside of congenital malformations, what colloquially people know as birth defects, outside of that leading cause, most of the reasons for neonatal mortality are actually obstetrically related. By far the most common is low birth weight from prematurity, usually due to premature labor. You have illnesses in the mother. You have problems with the placenta or the umbilical cord. You have problems with infection, which is usually related to delivery itself. So basically, if we want to improve infant mortality, neonatal mortality, again, it's really a matter of improving obstetrical care. How have we done? We've been very successful over the last 120 years or so. If you go back to when my grandmother was born in 1907 at home, at that time, if you were pregnant, you had an almost 1 in 100 chance of dying from labor or pregnancy-related complication. Everybody knew somebody who died in labor or knew somebody who didn't have a mother because their mother died in labor. And other than my medical colleagues here, I think that's a statement that hopefully few of you could make today. So we've seen a dramatic fall in maternal mortality, and corresponding with that, we've seen a dramatic fall in infant mortality over the last century. So why are we here today having this conversation? Because unfortunately, despite that tremendous success, in the last 25 or 30 years, we've seen a reversal of that trend. We've seen cases of maternal mortality start to go up. And while we're still far, far better than we were decades ago, again, to put it in perspective, in that column on the left, back in my grandmother's era, the rate of maternal mortality was measured in many hundreds. And as you can see, by the time I was in medical school in the 1980s, we'd gotten it down to the single digits. There were states out west where they'd go an entire year without a single maternal death. But over the course of my career, we've seen the maternal mortality rate go up and up and up. And while we're still far ahead of where we were decades ago, that's really not a fair comparison. A better comparison is how are we doing related to other Western countries? And the answer is that the U.S. has the worst maternal mortality rate in the entire Western world. And we feel that given our resources, that's simply unacceptable. So why do we focus on maternal mortality, even though the number of deaths is actually fairly rare? Because it really represents the tip of the iceberg. We know that for every case of a woman who has died from infection or bleeding or another cause, that's an indicator for many, many other patients who've had the same problem, but because of modern medical capabilities, we've been able to go in and salvage the situation. Nonetheless, that's a lot of morbidity. It's a lot of suffering. It's a lot of time lost. It's a lot of impact on the family. And frankly, it's a lot of impact on the state coffers. So for all kinds of reasons, we need to focus on this to see where we need to be addressing our efforts to try and improve all of those things. Why is it important to conduct a formal review of every case of maternal mortality in the state? It goes back to that old adage in the business world, you can't manage what you don't measure. If we were simply going by anecdotal data on why maternal mortality occurred, we would never really get a true understanding of what the problems were and how to address it. And the important thing for the legislature to understand is that by studying this, that negative trend I showed you is actually reversible. How do we know that? This is data from out in California. California, about 15 years ago, looked at that maternal mortality graph that I showed you, said that's moving in the wrong direction. We're the biggest state. We have the greatest numbers. That's completely unacceptable. They instituted a maternal mortality review committee where they reviewed every maternal death. They realized what the major problems were. It turned out in California it was related to obstetrical hemorrhage. It was patients who were bleeding to death in spite of all of our technology to stop that from happening. They instituted a set of changes in how women were cared in hospitals in California. It didn't involve creating new drugs or new technology. It involved changing the system of how care was delivered to make sure that all patients got everything that we knew they should get and got it in the right order and delivered in the right way. And you can see the impact on this graph as maternal mortality in the red line is continuing to go up and up. Maternal mortality in California has been cut by half. Why don't we just follow what California did? Well, it turns out, as you're going to hear from Dr. White and Dr. Weeks, our problems in Kentucky are very different from California, so it's very important that we study this on a state-by-state or even regional basis. So for those of you that weren't here 3 years ago, you should know that the legislature made a few small statutory changes that authorized the creation of a maternal mortality review committee. Dr. White will tell you more details about it, but basically every maternal death is now reviewed carefully as to its cause and lessons that we can learn. And I want you to understand that this has already made a huge impact in how we can care for women, as you're going to hear about shortly. And I want to thank you and your colleagues in the legislature for making this happen. I think sometimes as you zoom through legislation, you don't necessarily see the downstream impact, but as you're going to hear about, it's already made major changes to the health care of women in Kentucky. As physicians, we can identify what the problems are. We can do the medical science, and we can come up with evidence-based solutions. If we don't already have the solutions, we can do the research to find the solutions. Most of the things that we come up with can be implemented by non-governmental stakeholders, whether it's the Kentucky Medical Association or the Kentucky Nurses Association or the Kentucky Hospital Association or even grassroots education. Most of it does not necessarily require government intervention, but some of it does. For example, having a maternal mortality review committee would not have been possible without the actions of the legislature. And we'll be coming to you in the future with additional solutions that are also going to require some government action. So with that in mind, I'm going to turn it over to Dr. White and Dr. Weeks. Who's going next, Dr. White or Dr. Weeks?
Dr. Weeks. Yes. Go ahead, John.
Yes. Thank you, Mr. Chairman, committee members, for inviting me to speak today. I will pare down my remarks considerably. Dr. Goldberg has given an excellent overview of our challenges, and Dr. White has some very good data from the Maternal Mortality Review Committee. I'll spend a little bit of time talking about my personal background and experience here in Kentucky. I've been providing maternal fetal medicine services since 1993. I've seen many, many patients with complex medical problems, many of them with serious and challenging maternal or fetal conditions. But by the turn of the millennium, we saw the emergence of the opiate addiction epidemic. It's been unremitting. It's claimed many of the lives of our young women and devastated their families and children. We've done much to address this issue over the last decade or so, and there are some good stories to be told. But unfortunately, we've seen a continued transition from the use of prescription pain pills to injectable opiates, in particular methamphetamine. And so we're seeing a continuing rise in death rates in the state and in the country. It turns out that in 2010, at that point in my career, I was in academic medicine and charged with training and influencing, being a good mentor for residents. And as we saw more of these patients coming in, we weren't comfortable with their care and we felt ill-prepared. And that was my call to educate myself and to be as good a mentor as possible. And we now know that this condition is one of a brain disorder. People lose control of their decision-making and behavior. They don't intend to hurt their children and devastate their families, but that's where we end up. I will get quickly to how all this is influencing maternal mortality. There are a number of things that contribute to maternal mortality, but what we can say is in the last 4 to 5 years, there's been at least a 25% increase in maternal mortality attributable to addiction. And obviously, this wreaks havoc for families. And as these folks are moving through their disease process, they use quite a bit of medical resources. Dr. White, our Deputy Commissioner for Clinical Affairs, is going to share with you some important information from our Mortality Review Committee. But I would say we found fully 1/3 of the maternal deaths that occur during pregnancy or the first year afterwards are related to substance use disorders, drug overdoses primarily. So it continues to be an extremely challenging problem. I will say that most of those women who died of drug overdoses did have long-term serious substance use disorders with multiple relapses. Most were offered care and many initially engaged. Most had psychiatric comorbidity that was important: anxiety, depression, other more serious conditions, PTSD. We don't have enough mental health professionals to reach out to all the areas of the state that desperately need this kind of help. And this is one thing hopefully we can address in the near future. You'll hear from Dr. White that the Kentucky Perinatal Quality Collaborative would like the Commonwealth to be a great place for every woman to deliver a baby, and a great place for every baby to be born. And I would say our challenge going forward is to go beyond the perinatal period and make the Commonwealth a great place for every child to live, grow, and develop. I'll hang around for some questions if there are any, and I thank you so much for your time.
Thank you, Doctor. I'll just jump in, Dr. White, before I know you're going to kind of go in a bit more in detail, just to make the members aware. I know several members are here from last night, and we have a severe mental illness task force that's meeting now, and we had our first meeting, I think, last evening. This topic was discussed about our shortage of psychiatric providers really in the state. I'll throw the statistic out there: 350 psychiatrists for the entire state of Kentucky, about a little bit under 60 child psychiatrists for the state of Kentucky. We're woefully deficient in that regard. We've got to do a better job of trying to get people to get into the field and stay in our state to provide that care. It's really it's becoming a crisis situation in that regard. So we appreciate that, and it's just very timely. A lot of this, it's amazing how much the topics we discuss blend together when it comes to mental illness, when it comes to perinatal mortality, again, maternal mortality, all those kinds of things. So Dr. Weeks, it's very poignant and apropos. Dr. White, please.
Thank you, Chair Alvarado, and thank you, Chair Moser. For those of people who know me, to try to be brief about this topic is very difficult, but I think I have a PowerPoint that I can do that with. And are you able to see the slides now?
Yes, we can.
Okay, let me move. Oh, phooey. So I wanted to just give you as quick a snapshot as I can of what's happening in Kentucky right now. Are we where we want to be? No, but are we getting there? We are working on the infrastructure, the support systems that are going to help us, as Dr. Weeks said, make Kentucky a great place for a woman to have a baby and a great place for a baby to be born. I will show you information, and you do receive, the legislature gets a maternal mortality report every year from our Maternal Child Health Division here in the Department for Public Health. This data here just shows when we first started looking at the deaths. We started the Mortality Review Committee was in, we had our first organizational meeting in 17 and started in 18 looking at these deaths. And when you first look at this, you would say, well, 31% of the deaths came from overdose deaths. But actually, it was more than that. When you looked at those deaths, we found that some of the motor vehicle accidents had a substance use disorder factor. Some of the cardiac events were valvular disorders because of a cardiac factor. And when we actually added it all together, we had a little bit over 50% of our deaths were because of some type of a substance use disorder factor. And when we looked at our 2018 deaths, 48% of those were substance use disorder, 5% were probably. So again, we're over 50% of our deaths in Kentucky for a woman, either while she was pregnant or within 1 year after delivery, were related to a substance use disorder. This doesn't necessarily mean an overdose. As I said, it could be motor vehicle, it could be cardiac, it could be hypertensive, or it could be, and as far as suicide goes, the coroner is, the state medical examiner do not call something a suicide unless there's a note. So some of these overdose deaths, we don't know if this was an accidental overdose or intentional. I also wanted to point out, and I'm sure you've seen this map before, thank you for your legislation of several years ago when you made neonatal abstinence syndrome a reportable illness in Kentucky, and we are continuing to try to refine and improve the reporting from hospitals on our babies with neonatal abstinence syndrome, and that's a whole presentation in itself, but I did want to bring this in. These are the three cogs of the wheel, and I wanted to show you how Kentucky has fared on this. We developed the Maternal Mortality Review Committee. We've had a committee for 40 years, but that committee did not have the power that you gave this committee to be able to look at this in a very detailed and intricate way. In 2019, our Kentucky Perinatal Quality Collaborative started. And we'll talk about what that is, but it's a common table where the providers, the insurers, and the delivery hospitals get together and say, okay, let's look at our data. What are our problems? And are there evidence-based interventions that we can use to help all of our providers and delivery hospital? And I'm very excited to tell you that March the 1st of 2021, Kentucky became an AIM state. That's the Alliance for Innovation for Maternal Health. That's an organization that HRSA and ACOG, our professional organization, American College of Obstetricians and Gynecologists, has put together, where they pulled into bundles the evidence-based information that would be needed if someone wants to take a specific problem for maternal health and improve that. These are the members of the MMRC, the Maternal Mortality Review Committee. I apologize, there are lots of abbreviations, but I thought that was better than spelling out every single word on here. It would make the slide even busier. I just wanted you to see that we do have DPH staff that are assigned to this group, but none of us are voting members. Everyone that's a voting member on this group is an active practicing clinician. So we have OBGYNs and maternal fetal medicine specialists, neonatologists. As I said before, we have our chief medical examiner for the state. We have the state police. We have adult protective services. We have someone from the human trafficking expert. AWAN is the Association of Women's Health, Obstetrical and Neonatal Nurses, pediatricians, domestic violence advocates, certified nurse midwives, and OB anesthesiologists, and we even have a cardiologist who specializes in women's health because many of these deaths are cardiac. And then we have a representative from the Department for Medicaid Services. So this all started to grow legs when ASTO, the Association for State and Territorial Health Officers, I think y'all are familiar with that group of all the commissioners of public health across the state, chose 11 states to come to Washington, bring the representatives you see here, those 5 representatives. We met in a room and said, what is the one thing that we can do in Kentucky to make it healthier for women and babies? And it was by far, we agreed we needed a perinatal quality collaborative. The next year, when we went back for our next meeting, they added the Primary Care Association of each state to come. So we now have the KPCA is a member of our Omni group. That stands for, Opioid Use, Maternal Outcomes, and Neonatal Abstinence Syndrome Initiative. And even though they didn't add it, we have added to our Kentucky team the Department for Community-Based Services. We don't see how we can even begin to attempt to attack these issues and make our moms and our babies and our families healthier unless we have DCBS working alongside of us. So as I said, a quality collaborative is a statewide effort. You are looking at pregnancy, delivery, and that first year of life. It lives in the Department for Public Health because we felt like that was the best place for it to be, and I like to call it Switzerland. It's not UK, it's not U of L, it's not a Catholic system, it's not a Baptist system, it is Switzerland, and we are overseeing these things throughout the state so that we can be the neutral party that's looking at the best outcomes for everyone. And that goal is to reduce the rates of maternal mortality, neonatal abstinence syndrome, and improve the health outcomes as we've been talking about. Just to show you, these are the partners that started with us. I wanted you to see that this is not just the cabinet's work. This is a group of dedicated people in the cabinet that have reached out all across our state, and we continue to get more and more partners on board. As I said, we are now an AIM state, which is a big, exciting, big deal for us. This is a group, as I said, that can assist us with tools and technical assistance. They can help us with training. They have visual aids that can help us. They can know how other states have done these initiatives in their states and can give us some pointers and tips, and how to help us to get people the buy-in. How do we sell this to the hospital staff? Because we know that it's not just Dr. Me talking to another doctor, Dr. Goldberg or Dr. Weeks. This is a culture change. If we can go into a labor and delivery unit, give them the data, show them that how they approach these pregnant women and these delivering moms and what they do in follow-up of that delivery can save lives, they will do that. This will then spread into the prenatal care area so that we can continue to do that. Kentucky has chosen the bundle that we want to use at the beginning as our first initiative with AIM is going to be maternal care for substance use disorder. So there is a whole bundle that we can tap into to help us understand how we can do this efficiently, how we can do this in an evidence-based manner, and how we can get outcomes for our women. Working together to make Kentucky a great place for every woman to have a baby and a great place for every baby to be born. And I certainly agree with Dr. Weeks, a great place for every baby to live. The last thing that I wanted to talk about, and I think I'm doing okay on time, is House Bill 212. That bill was passed, and it is instructing the Department for Public Health in their maternal mortality report to give you information by race, by income, and by geography. So I'll start with the geography. If you've seen in that neonatal abstinence syndrome chart that I showed, or map that I showed, the numbers are very small in a lot of these reports, and to put a point on a map in a county really does take away that patient's anonymity. So we can report that by ad district, and when we do our report this November, we will be able to do that reporting so that you can get an idea of where these women, where their residence is, and that is on their death certificate. In the beginning, when we were doing maternal mortality review, we were only looking at death certificates and adding those numbers up. What we found when we actually started looking at those is some of them had been checked off as pregnant, but these women weren't pregnant. We actually had one that was a man that had been checked off as pregnant. So we're doing our numbers now are much more solid than numbers that we had in the past when we just looked at death certificate numbers. The second issue about income, we won't be able to provide that information because we use patients' medical records. So if Connie White dies and you pull my medical record, there would be no way for anyone to know what my income was. So we really don't have access to that. We could look at people that have Medicaid versus private insurance versus self-pay, but that's the closest thing to any kind of financial information we would have on these women. And as far as looking at race, we did include that in the last report that was recently released. I do want to point out that if you go to that chart, it says on there that if you look at the rate of death in Kentucky over the last, I believe it was the last 2 years, says that there was a 42.1 rate of death for Black women and a 17.2 rate for white women. That is shocking when you look at those numbers. However, when you look at raw numbers of those 2 years, in 2017, we had 39 maternal deaths. One of those deaths was a woman that was African American, and that was a homicide. In 2018, we had 58 deaths. 8 of those women were African American. 4 of them were a substance use disorder death. 2 of them were a death related to leukemia and lymphoma, and 2 of the deaths were severe hypertension related to preeclampsia. And sorry, that's my timer telling me my time is up. 2 of them, one of them was hypertension related to preeclampsia, and the other was a placental abruption. So as you look at the rate and see those high levels of those 8 African American deaths, there were 2 that were medically related, and the others, as we said, half of them were related to some type of substance use disorder factor. So this is the information I wanted to share with you, and I'm excited to be here and answer any questions that you might have.
Thank you, Dr. White, and thank you, Dr. Weeks, Dr. Goldberg, for your presentation. Really such an important topic. We know that we need to do better as a state. And I think we know that we have high C-section rates. I know I've spoken, somebody mentioned Arkansas a bit earlier in another presentation. They used to have a commissioner there who was a physician, an OBGYN, who took it upon himself to try to lower the C-section rates in Arkansas. And almost single-handedly would go from hospital to hospital system to work on trying to improve those numbers. We know liability plays a factor for us here in Kentucky in that regard as well. But whatever we can do to help lower our C-section rates, get our outcomes better, we look forward to your recommendations from all three of you. I mean, I think everybody, I can speak for everyone here that we all stand ready to receive recommendations on what we can do to improve these numbers from a government perspective. And obviously, I think there's some providers here in this group as well that whatever we can do as colleagues, just as physicians, I think we all want to see our numbers improve in our state to have better outcomes for our patients. We've got a few questions. The first question is from Senator Adams.
Thanks, Mr. Chairman. And I don't know if this is a question more appropriate for Dr. Weeks or Dr. White, but in 2018, we passed Senate Bill 250, and that was requiring pregnant women to be tested for Hep C. Where are we on the implementation of that bill, and what kind of data are we able to extract from that?
We are in the instructional phase to get physicians to do that. Our viral, I don't have those numbers in front of me, I apologize, and we can get you a report, but our viral hepatitis program is looking at those numbers. We already knew that we have one of the highest Hep C rates in the country, and so I just don't have numbers, but I can get that for you. I know the right people.
Sure, I appreciate that. And could Dr. Weeks comment on that? I know, I think Norton is actually participating.
Mm-hmm. Oh, yeah.
Yes. So really, Norton's, a lot of the private practices and physicians moved in that direction years ago, even before this initiative. So I'd say essentially 100% of the patients are getting hepatitis C testing as part of their routine prenatal care, with updates in the third trimester, if appropriate, for the high-risk groups.
Thank you. I appreciate it. You know, just with the whole substance use disorder and the amount of pregnant women who are addicted, I just think this is a really critical piece as we move forward with trying to lower our rates of maternal mortality. Thank you, Mr. Chairman.
Thank you, Senator. Before I go to the next question, also, I know Dr. White, you'd mentioned about House Bill 212 and some of the data that you couldn't report. If you've got some recommendations on changes to that going forward for next year, that we need to change in there to make sure that it's reportable data, that we can, I think you get the gist of what I think the legislature was trying to get accomplished.
Sure.
But if you have recommendations for that, please send that to us for the next session. We'd be happy to make those accommodations. Next, we have Representative Birch.
But no, they won't do it. Choose to collect the data. The only one doing it is Norton. Get his microphone.
What are these other countries doing that makes them better than us? Somehow, this doesn't seem to yet be real. I spent 4 weeks in France, and I can tell you right off some of the things that they were doing. One was they took good care of kids from the time they were born. The national priority. They took care of senior citizens. They took top dollar. Daycare was the second to none. The hospitalizations, I went to 3 or 4 hospitals. They were equivalent to or better than ours. What are we not doing that would make these other countries better and having better results than we are? If I know that there's 10 countries that are probably industrialized countries that are the top best, I'd pick out that first 2 or 3 and find out what they're doing right and try to. It's no sin to copy, unless you get caught on an exam or something. But
yeah, thank you for the question, Representative Birch. I know your microphone was off, so just to summarize The question is that given the United States' poor performance on our quality outcomes, what are other countries in the Western world doing that we are not? I don't think the chairs are going to allow me the time to fully answer that question, but I'm certainly happy to have a discussion with anybody.
Just a short yes or no
right.
would be
I will say that it comes part and parcel with a bigger problem within the U.S. healthcare system, which is we spend more per capita than any other Western country, and at the same time, we have worse outcomes for the money that we spend. So we have a value problem, basically. We're not spending our money wisely. It's not really a deficit of technology. It is a deficit of designing our system so that the right technology gets applied to the right areas, the right patient in a systematic fashion. The details of that, of course, are a very long conversation that I'm happy to have with anybody at any time.
Thank you, Doc.
Next, Representative Wilner.
Thank you very much. And thank you, all three of you, for really just a remarkable presentation, very helpful information. I appreciated your saying that every maternal death is reflective of folks who don't die but struggle with the same issues. And we know that some women die from suicide related to pregnancy and mental health concerns. And we have estimates from 1 in 3 to 1 in 5 women struggling with some kind of postpartum mental health complications. And that has, even when the woman doesn't die, that has tremendous impact on child development to have a mother who's depressed or anxious and unable to engage with the child. And that's a whole big topic, I know, but I wonder if you have any insights about that and what we might be doing policy-wise to be able to address that issue more directly.
If I could make a couple of comments about that, it's Dr. Weeks. There is a growing awareness of this condition being undertreated. So there are some authorities that believe it is the most common pregnancy-related complication, and 75% of women who suffer from this are undertreated. Just last week, the Kentucky Perinatal Association had an annual meeting, and this was a topic of discussion. So we started with sort of general education and promulgating some of the data and actually some of the information that says primary care physicians can pretty easily screen for depression and initiate care. Again, for the more complicated cases, we don't have enough mental health professionals to help. Those who screen positive, and especially if they've got a substance use disorder or bipolar disease, we need more psychologists and psychiatrists to refer to. From a policy perspective, if the Mortality Review Committee has identified suicide as a reason for some of these deaths. As Dr. White spoke to, not all those patients we think leave notes, but we'll be making some changes in how we do things through the Kentucky Perinatal Quality Collaborative, and addressing mood disorders in pregnancy is on that list of priorities. I don't know exactly when we're going to time that, but it is on the radar.
I'm sorry.
Sorry, go ahead.
I was just going to say, in terms of the 75% of women who are undertreated, we know that women of color, Black women in particular, are disproportionately undertreated. So that's my understanding anyway. But I'll sorry, Dr. White.
No. I love to brag about the work that our team has done. We were one of the states picked over the last couple of years to be part of the PRAMS, P-R-A-M-S. That's the Pregnancy Risk Assessment Monitoring System that the CDC provides, where we actually contact women after delivery and ask them questions about what was your care like, what did you experience. That's data that's not captured anywhere else except in this. So we are just now analyzing that data, looking at what kind of care they got, how did they feel after delivery, some real some real information from the patients themselves about, did they have depression? How were they treated for that? Were they ignored, as you said? And we also then got extra funding to do an opioid screening. So if these women did have a substance use disorder, they agreed to another phone call contact 6 months after the first. So we contacted them 6 months after delivery, and then another 6 months later to get some information. So we're going to have some really robust data to use to help us as we design what we need to do next. One thing that we're doing to kind of address what Representative Birch was talking about is we are in the process, we just spoke about it yesterday at the steering committee, of developing in the Kentucky Perinatal Quality Collaborative in KIPQC, a maternal mortality review subcommittee, because every patient we look at in the maternal mortality review committee, there's a spot where we list recommendations. What would happen if this woman could have kept her from dying? Those recommendations really have no place to go. And so we're going to take them at KIPQC and look at those recommendations and say, is there a program anywhere that's just maybe not working? What could we do? What recommendations could we make to kind of put that on steroids and make it work? So we're going to really try to take the work that the MMRC is doing and actually give it legs. And I know that, as Dr. Weeks said, because he is on the MMRC committee, and thank you publicly for doing that, Dr. Weeks. He's the vice chair of that committee, to actually make this actionable now. And that's going to be a big issue, is postpartum depression and mood disorders.
Great. We've got 2 more questions. We got another presentation to go. It's going to be tough for us to get all these in. I'm going to go to Representative Marjan next.
Thank you, Mr. Chair, and I'll be really quick. I don't care who answers this, but how many pregnant women come in that have had no prenatal care, that just show up at the, they are maybe one time at a clinic or something? I think, no access to prenatal care is probably a big factor in issues.
I don't have that number. We do see that. And again, often it's because of a substance use disorder. They're just afraid to come in. They're afraid they'll get caught. And so they come in with no care. But there is a number. I don't have it. I'll find it for you, Representative Marzian.
And I had one other question. On your substance abuse disorder and maternal mortality, is that also fetal mortality as well? If the woman dies of the overdose, the fetus would too, right?
Help me, Dr. Weeks. I believe they've all been postpartum, haven't they?
We've had 1 or 2 that were antenatal, but you're right. The vast majority, it's after delivery. Usually 3 to 11 months after delivery seems to be the most common time frame.
Thank you. Thank you, Mr. Chair.
Truman Mosier.
Thank you, Mr. Chair. Thank you very much for this great presentation. This is very interesting and informative and timely. I appreciate the work of the Kentucky Perinatal Quality Collaborative and all of your work. I just have a couple of clarifications. And I agree completely that, really collecting this data and understanding the data is only going to lead to better policy decisions and prioritizing any recommendations that come out, and reevaluating the systems of care and the appropriateness of the systems of care. So I appreciate your comment, Dr. Goldberg, about that. But Dr. White, you mentioned a maternal care for substance use disorders bundle. Can you expand upon that a little bit? Is that already implemented?
Well, no. We just became an AIM state in March. And so we are meeting with the AIM folks. They're going to help us with different types of evidence-based interventions that we can then go from hospital to hospital. We've actually are going to start here in another month or 2 with 6 hospitals that are going to be our first pilot projects to take those interventions and see how can they seamlessly integrate that into the work that they're doing, so we can find something that works well in our Kentucky hospital. So it's interventions, it's training people about quality improvement. It's the whole gamut of a quality improvement program.
Okay, that sounds wonderful. I look forward to hearing those recommendations. And then another really quick clarification. Somebody was talking about the number of psychiatrists and I guess, child psychiatrist in our state. What was that number again? I'm trying to get my son to come back to Kentucky.
That was Dr. Alvarado.
350 psychiatrists for the entire state of Kentucky. And in that 350, about 59 child psychiatrists. Half of those psychiatrists are cash only, don't take any insurance.
That's right.
There's a major shortage.
Okay, I will relay that.
Fabulous. Dr. Berg, very quickly.
Well, thank you, Chairman, and thank you guys for an amazing presentation. Just very quickly, there's always been, I guess, on my part, an assumption that pregnant women are more susceptible to domestic violence. Are you all seeing domestic violence or violence against pregnant women at a rate that's higher than that against the general female population? And is that impacting your maternal and fetal mortality rates?
Dr. Weeks?
Dr. Weeks, you want to take that?
Yes, it could be difficult to get a handle on how often that's really happening during the pregnancy, but we've seen several women that we think are suffering from that. Fortunately, in most instances, they're asked about it, but haven't admitted to having issues, and therefore haven't gotten any special care or referrals to places for protection. And we've had a couple of homicide victims that had probably domestic violence ahead of the final event. Whether or not that's greater than the patient population in general, I'm not aware of any studies that have investigated that, but to your point, yes, it's well known that women who suffer from domestic abuse are most likely to die or be killed during the pregnancy.
Very good. Thank you very much, doctors. We appreciate your time today. We know all of you are very busy. Appreciate you coming and testifying before our committee. We look forward to your recommendations in the upcoming year and the next session ahead, and helping however we can. So thank you very much for the work that you're doing.
Thank you.
The last thing on our agenda is another very important topic. I want to make sure we give some time to is a presentation on cytomegalovirus in newborns. We have a couple of individuals here today. Sarah Roof is Executive Director of Kentucky Hands and Voices, and Sarah Strevel, who's a parent. And they're both here today to talk a little bit about CMV in newborns. I know there was a proposal or a bill that had been filed by Senator Wise this past year. We wanted to make sure we had some discussion around this topic, and again, some awareness around this disorder. And again, as I mentioned earlier, a lot of times physicians and practitioners are learning about things all the time, and sometimes it just takes a reminder of what these infections can do to our children to have them be front of mind. So, ladies, if you'd like to introduce yourselves for the record officially, and then begin your testimony.
Yes, thank you for having us today. My name is Sarah Roof, and I am with, is it this one?
Yeah, you gotta push the button. There we go. Thank you for having us. I'm Sarah Roof. I am with Kentucky Hands and Voices, which is a statewide organization that supports families of children who are deaf or hard of hearing. I also serve on the advisory board for the Early Hearing Detection Intervention Program in Kentucky and the Family Advisory Council for National Center for Hearing Assessment and Management out of Utah State. But primarily today, I'm here as a mother and as Sarah's cheerleader and moral support and clicker for the presentation. So thank you for having us.
Hello, thank you so much for having us today and for letting me speak. My name is Sarah, and I work with Hands and Voices as a guide by my side, and I'm also a community chair alliance for the National CMV Foundation. But most of all, I'm Bella's mother, and that's what I'm here to talk about is Bella and our initiatives with cytomegalovirus.
I'll add while this is coming up. I don't see it on here. So we are here as a part of a larger committee of physicians from University of Kentucky, University of Louisville, also representatives from the National CMV Foundation, Kentucky Commission for the Deaf and Hard of Hearing, and the Kentucky Council of Developmental Disabilities, among others. But you get two moms today, so we're happy to answer as many questions as we can. And anything else beyond that, we will field to some of our physicians. In the interest of time, we have kind of done our presentation a little bit differently. So we'll go through a PowerPoint, and then we'll also share a video of a shortened piece of a webinar that we did earlier this month. And I'll also mention Dr. White referenced the Kentucky PQC, and they're also doing a webinar on CMV later in July. So a lot of interest surrounding that right now.
Okay, this is Bella, and Bella was born on February the 5th. We had a completely normal pregnancy, no complications. However, she was born with symptoms at birth. She was born at a local hospital, therefore they was not sure what was going on. She was stabilized and then life flighted to the NICU. It took about 3 days for us to get the diagnosis, and she was diagnosed with cytomegalovirus, also known as CMV. Come to find out, this was a very common virus, but yet one that was highly unknown. And those statistics are actually 90% of women and families know nothing about CMV. CMV comes with a host of medical issues. So this is Bella's list alone, and is not complete. Each one of these kids have a lot of these, but not all of them have the same severities in each one. So Bella had microcephalia, which is the small head, pylomicrogyria. I slaughtered that, but she had the abnormal brain. I think it's moving on its own.
It is.
Sorry.
No, that's okay. I don't know how to go backwards. It's going all the way through.
I think you just click back. No? Okay. So we'll go through it quicker. She had brain calcifications, which called seizures. She ended up with a seizure disorder known as Lennox-Gastaut syndrome, which is a very rare but yet severe seizure disorder. Cortical vision impairment. She was legally deaf in both ears. She received cochlear implants for those. She had respiratory failure that was as part of cerebral palsy. So a lot of these complex issues and disorders would work against each other and just create perfect storms throughout. But that's not who Bella was. Bella had the most beautiful blue eyes and infectious laugh. So she would get to giggling in the hospital, which we spent a lot of time in the hospital, and doctors would come in just to see who was laughing and to watch her. Super nosy. She had to know everything. We put her cochlears on, and she never wanted to take them off because she had to hear and see everything. She had the most magnetic personality. So I'm not a super, meet everybody person, but when I took Bella, it's okay. When I took Bella in, we had to talk to everybody. Bella loved water. We said water was her magic. She loved lights and music, any type of music. She loved to be outside. She loved the wind and the trees. She loved to go camping. She had the strongest personality. She was very opinionated, determined, and persistent. So everything had to be Bella's way or no way. And she didn't need any words, as you can tell. She let us know what she liked and didn't like. Bella was loved by many family members. Bella was the last of 7 and part of a blended family. So all of these lovely gentlemen and little girl here welcomed her home and loved her dearly. Bella's struggles increased, so her seizure activity started to get a lot worse. We had it controlled for about 6 months, and then after that, it just got worse and worse. So at the end, we were having approximately 10 seizures an hour. She needed more and more medication. It got to a point where we wasn't sure if it was going to be the medication that took her or the seizures. Autonomic dysfunctioning got really bad. So autonomic dysfunctioning just caused her body to have extremely high fevers for no good reason. respiratory issues, digestive issues, all that fell under the autonomic dysfunctioning and continued to get worse. We spent at least 6 months from February of 2018 to June 2018 in the hospital. And in that time, we received 4 major procedures. So we lost Bella in April of last year. So April the 7th, she succumbed to those disorders. And since then, we have determined to educate others about CMV, advocate for Bella's bill, and create a community for CMV families. I made a mission after she passed that I would connect the families in Kentucky, because community had been one of the most valuable parts of our journey, and it was really hard to find people with CMV. And so this is what I've done. I've connected over 39 families so far in less than a year, and we're still collecting stories and families. So I want to show a few of the families from Kentucky and just tell you a little more about why we want Bella's bill and we want things to change. Rowan is only 4 months old. Rowan is one of a twin, and his mother was a pharmacist, and she was home pregnant with a toddler during COVID. However, she was not reminded or informed about any of the precautions to take while at home with a toddler. Toddlers are shedding CMV. 80% of them are shedding it, and we don't know it. Rowan's life might have been changed if she had been reminded. Kaylin is 25. Her mother worked as a CNA. CNAs, childcare workers, nurses, all these are very high-risk categories. She worked as a CNA that actually had an outbreak in 1996 of CMV. However, she didn't know what it was. They didn't tell her. And nor did they give her precautions or precautions for her unborn child. And this is the results. Her family could have been spared if she had known. June is 6. She was not diagnosed at birth. She was not diagnosed after she held hearing tests. She was not even diagnosed after she began having infantile spasms. She was 3 months old before she was diagnosed, and therefore she lost out on some of those early interventions, the antiviral medications that could have been given at birth. If she was diagnosed sooner, we could have changed things for June. Cameron was 6. Cameron's father had CMV. However, the family was not educated, and nobody was concerned about what that would do to the unborn child. Cameron wasn't even tested at birth. He wasn't tested until later when he started having symptoms and not meeting all of his milestones. Destiny's 5. Her mother was a nurse. Nurses are high category, but again, they're also trained. As a trained medical professional, she said she was taught very little about CMV. Very little. And she said it surprises her how little, not only her, but all her colleagues knew about this awful disease that has took so many lives. We lost George. He'll forever be 2. His family was forced to relocate due to the severity of his disease and then his loss. The burden of care for these kids is so great that we can't do it alone. So this family actually had to leave Kentucky in order to be closer to extended family, to be able to get the medical care and the day-to-day care that he needed. And this is just a few of our stories. Like I said, I've connected 39 families. We have a few others, but you can see the counties here. We have these divide up into 19 counties. 7 of those have passed. We actually surveyed some of those families. So 30 families we surveyed. 40% of those had been diagnosed by the time they were 3 weeks old. So that's over half are not getting diagnosed within that first 3-week time frame, which is what they need to start the antivirals. 42% started the antivirals at birth. So there's over half are not getting the antivirals. Half of these are all in Kentucky Medicaid. And I broke that down just a little bit. These numbers, the health conditions on the left there, the health conditions were so great that I couldn't put all the numbers on here. So I narrowed it down to like the top 10 so that you could see. And that bottom is developmental delays. You could see 83% of these kiddos all had developmental delays. Hearing loss, vision loss, seizures, and this is just our survey. This isn't something from someone else or some made up numbers. This is actually the families that we connected. We actually polled them and surveyed them, and this is from their answers to our questions. So specialized equipment, this is just goes into showing you the financial burden, not just to us, but to the insurances and the Medicaid system. This is actually part of what we had to purchase for Bella and what was purchased through Medicaid for Bella. So you can look and see this is just average cost. She spent at least 100 days in the hospital. That's right around $400,000. And then we're just talking a hospital stay there. Medication for 3 years, it was over $200,000. Cochlear implants, she had bilateral cochlear implants. That's right around $200,000. PICU stays, life flights, VNS. She had a VNS that we swiped for seizures. Handicapped vehicles, respiratory vests, wheelchairs, $12,000 for a wheelchair. Specialty beds, cough assists, floor setters, standards, oxygen. Again, the list had a whole page by the time I got done, sitting down and just trying to itemize everything out. But this is the cost that these families are looking at. We're going to now show a video. This first one will let you hear from some of our professionals that's on our team.
I think I have it this time, Becky.
And then after that,
hi everybody. My name is Laura.
And then after this, we'll introduce you to some of the families. And you can see a slideshow.
And one reason this, like I said, in the interest of our time, our physicians were already scheduled for clinic or the OR today. So some of them weren't able to be here, but we wanted to share just a clip from our webinar that we did to kind of help give you a little bit more information about CMV.
Stadler, and I'm a pediatric infectious disease specialist at University of Kentucky, Kentucky Children's Hospital. Many of you are aware that June is CMV Awareness Month, and the National CMV Foundation has supplied these slides of the 3 themes that they have tried to emphasize to the U.S. Cytomegalovirus, or from here on out I may continue to say CMV, is common. It's thought to be the most common virus transmitted from a pregnant woman to her unborn child. 1 in 3 pregnant ladies who get CMV will then pass the virus on to their baby. It's thought in the US that the percentage of babies born with congenital CMV is roughly 1%, or some estimates are 1 in 150 children are born with congenital CMV infection. Perhaps the most important thing shown on this slide is that congenital CMV is more common than the 29 combined metabolic and endocrine disorders in what's referred to as the recommended United States newborn screening panel. So when we think about screening for infant metabolic screening for our state, CMV is more common than the 29 disorders that are already included. The next thing that the CMV Foundation wants to emphasize is CMV is largely preventable. It's my hope that during my career, we will have a vaccine available to prevent congenital CMV infection. Until then, the measures are largely common sense. They're easy to do. So the CDC and others have endorsed strict hand washing with soap and water, for those who come into contact with young children. We know that pregnant women who have young children in the home, work with young children, are at the highest risk for having CMV. Some of these measures may seem very common sense: to avoid direct contact with saliva of children under the age of 6, to wash your hands after contact. There are a lot of studies in children attending daycare or childcare centers of both the children and the parents of children attending daycare, and they show that infection is quite common. It's spread by saliva and urine. So our childcare workers should be using what we refer to as standard precautions. This is soap and water, washing their hands with gloves with each and every diaper change when they're doing diaper changes for young toddlers or babies. Other common sense recommendations are shown here to refrain from sharing utensils, drinks, or toothbrushes in children under the age of 6. The last theme is that CMV is serious. Every hour, one child is permanently disabled by CMV. It's thought to be the leading non-genetic cause of childhood hearing loss. CMV may cause vision loss, mental disability, microcephaly, cerebral palsy, behavioral problems, and seizures. In our country, it's thought that roughly 400 children die per year from CMV. But there is a connection between miscarriage and stillbirth, so this may largely be an underestimate.
Good afternoon. My name is Dan Stewart. I'm a fellow of the American Academy of Pediatrics. I'm a professor of pediatrics and international pediatrics at Norton Children's Hospital and the University of Louisville School of Medicine. I'm the medical director of the ECMO program here at Norton Children's Hospital. I've been the director of our neonatal intensive care unit, which is a level 4, for approximately 20 years, recently stepping down from that role. So today I have the privilege of talking to you about universal screening for congenital cytomegalovirus. So CMV too is really one of the leading congenital infections worldwide. So congenital CMV infection meets many of the criteria for screening, allowing for early detection and intervention to improve clinical outcomes. This is very similar to when the state of Kentucky approved universal newborn hearing screening. So what are the criteria for universal screening program? Well, you've got to evaluate the incidence, the disease, as well as the prevalence. The incidence is how many new cases have been diagnosed, but prevalence is how much exists in society. So we look at both the incidence as well as the prevalence of a disease or condition. And then diagnosis. Do we have a reliable way of making the diagnosis? This has evolved, as I will talk about in some subsequent slides, over the last few years. And I think we're at a point now where we can reliably make the diagnosis. And then is there treatment available? Well, certainly there are. So antiviral agents are now available. Speech language therapy is also available, as well as cochlear implants. And then another facet that's got to be considered is the cost effectiveness and the burden of the disease. And as you will hear in some parental presentations, the emotional cost to the family is part of the burden of the disease. So I will close with this thought. If it were your child or your grandchild, I think that you would certainly agree that it's time for universal testing for congenital CMV is a bonus.
She's up at 6 a.m. to dress and feed him. She helps him from the wheelchair to the van. And 2007. Since the doctor placed that baby in their arms, Daddy's working days and nights and on the weekends, and you wonder how it's weighing on his heart. I asked him how he does it every day. How do you keep on going with such faith? And he said, when those eyes are looking up at mine, every trial, every fear in that moment disappears, and you realize that it's all worthwhile when it's your child. I knew you before I knew your name. I loved you before I saw your face. I longed for you for all of that time, and I held your heart in mine. I kissed you 100 million times. I tasted the tears that I cried. I held you, my beautiful child, and I'll keep your heart in mine. I love you to the moon and back, as long as I live. I knew you before I knew your name. I loved you before I saw your face. I longed for you for all of that time, and I'll keep your heart in mine.
We can't change Bella's story. We can't change the stories of those that you saw on this screen, but we can change the stories for future Kentuckians. And we're asking for your help with that as we push for awareness and education to pregnant mothers, to physicians. We also are asking for universal screening because, as you'll see, that is coming, and we would like for Kentucky to lead on that issue instead of follow. Thank you.
Thank you very much. I don't know if anybody may want to mute their. If you're watching on Zoom, you may want to mute your microphone there. We do have one comment, Senator Wise.
Thank you, Mr. Chairman. Mr. Chairman, I want to thank you for the opportunity to present this during the interim, and also Co-Chair Mosier. I know in the session it'd be very difficult to do something like this with how busy we get with bills, but to focus in on your story and the stories of countless other families. I want to thank both of you for your advocacy, Sarah Roof and Sarah being a constituent in my district. Thank you for your strength today. This is very difficult to be in front of this committee. That's why I love this committee, is hearing stories and sharing your story and Bella's story. My question is, when we look at universal newborn screening with CMV, how many other states do we know that are doing this for CMV?
Okay.
Do we have those statistics?
There are currently no states that are doing universal screening. It has been placed before the U.S. committee to do universal screening from a national standpoint, and that's why we would like to see Kentucky lead on this issue. There are some states that are doing targeted screening, and University of Kentucky does targeted screening as well. So if a newborn is in the NICU or fails their newborn hearing screening, then they will automatically do a targeted screening there as well.
Perfect. Thank you all so much. Look forward to continue to working with you all on this issue as we go forward through the interim into the session. Thanks again. Much appreciated.
Thank you so much.
Thank you, Senator. Any other questions from the committee? Thank you all for the, I'm sorry, Representative Mosier.
Thank you, Mr. Chair. Sorry. I, as a former NICU nurse, I am keenly aware of this issue, and thank you very much for your presentation today. I can't imagine how strong you have to be to come in and share the story, so thank you. Do you know the cost of universal screening, and why aren't we considering this?
I don't know that there's an exact cost yet. It is rather costly. I know when the bill was presented this session, it was looked into. I think the issue is there is that upfront cost, and as with a lot of things, it comes with a lot of costs on the back end. So even some of these people that presented earlier, in the long term, they say that it will actually be either cost savings or cost neutral. That comes from a study in JAMA Pediatrics that released that it's either cost neutral or cost effective in the long run for universal screening.
Right, okay.
Currently, they have, am I still on? Currently, they have 3 different ways that they can test for CMV. They can do a blood test, but that's not how they prefer. They like to do the urine test. And so the urine test, a lot of our facilities are not prepared for that. And therefore, it's going to have to be transferred from one facility to another. So there is some hang up in how all of that's going to come about. They're currently working on bringing the saliva test up to par. They have it a lot higher, but they're not ready to put that out yet. So what they hope in the future is going to be a saliva test that we will do first. And then if that is positive, then they will follow that up with more testing.
Okay, and so I'm not sure if you know the answer to this question. Maybe Dr. Goldberg would know this. Is there prenatal testing for CMV or any antiviral treatment?
Not for the infant. There is for the mother. So we can ask that we be tested. Absolutely.
Yeah, from a technical standpoint, you can screen for CMV infection through a cervical swab. There is no data yet supporting the utility of that.
Okay. And no antiviral treatment during pregnancy?
Not currently, no.
Okay. Thank you.
Representative Bentley.
Thank you, Mr. Chairman. I'm glad you sat down there, Doctor. My question deals with cellular immunity. Since you pictured all children, have they studied to see if there's a breakdown in CD4 or anything like that?
You're wandering way outside my area of expertise, I'm afraid. I'm actually trained as a gynecologic oncologist, so I'm going to have to defer on that one.
Your cellular immunity attacks this virus to keep you healthy. And I'm wondering if there's a breakdown in that immunity system because they're all children.
Well, and no, most people, it's a high percentage that get CMV in their lifetime, very high. It's just when a woman who is pregnant contracts it and passes it on to her newborn child where you see these other effects. In you, it's going to present probably as a common cold, or even in a young child. It's when a pregnant woman gets it.
I know that.
Yes.
But if you have it in your body, your cellular immunity, it takes care of viruses like that. My question is have they looked into any breakdown in the immunity of the children to see if that's causing the problem?
I can chime in here if you don't mind. So with kids, remember their first 4 to 5 months, they're completely dependent on maternal antibodies that they've received from mom to fight infections. If kids are going to have immunity problems, you're not going to see those until they're about 4 to 5 months of age. So a lot of kids will be doing fine. They've been exposed. Mom's antibodies are floating around through their system. Then when their own immune system kicks in about 4 to 5 months, if they have a problem, they'll start kicking with tons of bacterial, viral infections at that point in life. So you're not going to notice it in a newborn. It'll have to be only to be done either through mom's either positive or the baby's positive, and they're dependent on their mom's antibodies. That isn't a sufficient enough antibody level that virus can take off, and they don't really have an adequate antibody system to help knock that out when they're newborns. So a lot of that is a kind of it's after they're born is the issue. The hard part with some of the concerns we had with the bill originally, there is cost. There's one state, I think the state of Indiana does across the board screenings on every newborn that comes through. A lot of states are doing awareness to make sure that moms are aware that they can be concerned with that. Some are doing targeted screenings. That was always my impression, but the state does not require that here because I was always trained at UK that we did. If a child failed an algo or a hearing test, they got an automatic screening for this, but that isn't being done necessarily across the board. So it becomes a cost. And then there's also false positives. Kids who might test positive, don't really have it, are going to get a full-blown treatment of something. What's the consequences of that? We don't know that either. So there's a lot of unanswered questions. It's important to bring this topic for discussion. We thought it would be important to bring it here. We can all hear about it. I'm sure it'll come back for us to discuss further. But to know that it's on our radar, and a lot of states are taking action to either increase awareness through targeted screenings or to do full-blown screenings across the board.
My follow-up question would be then, do nursing babies have less incidence?
Moms can transmit antibodies through breastfeeding, and that's always important. Again, it just depends on how big of an antibody response. But a lot of the maternal babies' defense are going to be there's a lot of that's transmitted orally for oral defense for kids. We know that kids do have less infections, bacterial infections in particular. I'm not sure about CMV exactly, if that's actually reduced.
Thank you all.
Yes, Senator Berg.
Thank you, guys. Real quick question. My understanding with CMV is that it's that the children that are affected, this is predominantly an in utero infection. These children are already born with the microcalcifications and the microcephaly and the brain development abnormalities. So by the time we're screening these children, they either have the sequelae of the disease or they don't. And CMV is an extremely, it's everywhere. Everybody has it. It's only a certain small subset of children that actually become affected by the disease in utero. My question, honestly, and believe me, your presentation is awesome. My heart goes out to you and your family and everything you have been through. But as a healthcare provider, what I have to look for is, what are we going to do differently? How is this going to impact us? And if we're screening every child, it seems to me that the cost of that and the potential cost of false positives, as well as even potentially false negatives, the deed is done. By the time that child is born, they are either affected with this or they're not going to be. So to automatically screen every child when we can wait a couple of weeks and figure out who's got the hearing losses, who's showing the stigmata based on physical examination, I'm just wondering, how is it going to impact outcome? How does it impact treatment? And is it worth the cost?
I'd like to answer that. The antivirals that they are given at birth can actually prevent or slow down the development of hearing loss and vision loss. So those are actually degenerative. So yes, the brain calcifications, there was nothing they could do about those. But the hearing loss is degenerative. It's almost as if they were born with old people's ears, and so it can degenerate within a year and it could be gone. But if they could start those antivirals at birth, we could possibly prevent that. And then the vision loss is often diseased eyes. If they can catch that early on, we could prevent. Little Solomon lost an eye because of this. He might not have lost that eye if he had got the antivirals that prevented this. We can't stop everything, no. And it needs to be stopped on the front end, yes. But this is what we could do right now. And a lot of these mothers, they knew nothing about CMV. We're educated on Down syndrome. We're educated on all these other things, but we knew nothing about CMV until we're handed a baby and said, here.
And some are asymptomatic at birth, even though they are positive for CMV. And so the developmental delays that come because they are not diagnosed, there's then the developmental delays and the costs that come with that because they go undiagnosed. And you really can't officially diagnose them after about 3 weeks, but they could have progressive hearing loss or other developmental delays on down the road. And so that's why it's important, and that's why there's a push for universal, is to get some of those who are missed and then progress later.
As a follow-up, what I have not seen, and I've actually looked for this, so if you all could provide this for me, I have not seen data that says the early use of antiviral in the first 3 weeks after birth protects these children from any of the long-term sequelae of this disease. Does that exist?
Yes, it does.
We'll get it for you.
I would really like to see
Yeah,
it. Thank
absolutely.
you.
Thank you. And our last question, Representative Sharp. Very good. Okay, well, very good. Then there's no last question. Well, thank you all very much for your presentation. We appreciate that. And a touching tribute to all those children who are suffering or have suffered from that disorder. I want to remind the members our next meeting will be on July 21st at 1 p.m. Same place. Any other questions before the committee? If not, we stand adjourned. Thank you.